Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hello, my name is Sally Hodder. I'm a professor of medicine at West Virginia University, and I want to welcome you to episode 2 of 4 Clinical Clips. Over the past couple of years, glucagon-like peptide receptor agonists have been all the rage, and millions of people are on them, maybe many of you. However, there are very limited studies in persons with HIV. In fact, Dr. Todd Brown yesterday, in introduction to the session on GLP-1 agonists, remarked that in 2022, there were more than 1,400 papers on GLP-1 agonists in the general population and less than 20 on persons with HIV. So, at CROI this year, there have been several studies addressing GLP effects in persons with HIV. And in the first study by Dr. Heidi Crane and her colleagues that looked at the impact of semaglutide, one of the commonly used GLP-1 agonists, she looked at it on weight in persons with HIV. Participants were persons with HIV who initiated GLP-1 agonists. There were 222 individuals in the cohort. At 1 year, the average weight loss in this group was 6.5 kilograms or 5.7% of body weight. And in fact, the amount of weight lost correlated with higher BMIs, though the percentage of weight loss was similar across the groups. In a second study that was presented by Dr. Eckert and colleagues, they assessed the effects of semaglutide on inflammation and immune activation among persons with HIV and lipohypertrophy. Individuals to be eligible for the study had to have a BMI of 25 or greater, had to have a viral load less than 400, and had to subjectively report increased abdominal girth after antiretroviral therapy. After a lead-in phase of 4 weeks to assess for stability of lifestyle habits, individuals were randomized 1-to-1, 54 individuals in each arm, to semaglutide and placebo. And the semaglutide was then titrated up over 8 weeks to a full dose of 1 milligram weekly. The outcome measures were quite impressive. The visceral adipose tissue decreased 30%, body weight 10%, and there were also significant decreases in markers of inflammation. Importantly, semaglutide caused decreases in several of the biomarkers, but that was not correlated with the amount of weight that was lost, which was really quite interesting. In a third study presented by Dr. Jordan Lake, ACTG 5371, they assessed semaglutide impact on persons with HIV and metabolic dysfunction-associated steatotic liver disease. Now, that's a fancy new name for what we used to call non-alcoholic fatty liver. In this study, individuals had to be on suppressive ART, had to have an elevated waist circumference, and insulin resistance, as well as greater than 5% of intrahepatic triglycerides, as was measured by MRI. And the study design was a single arm. Semaglutide was initiated at 0.25 milligrams weekly and titrated up to a maximal dose of 1 milligram a week. The significant improvements were really seen. Overall, 58% of participants had greater than a 30% reduction in intrahepatic triglyceride content. And I found the next one just amazing. 29% had complete metabolic-associated steatotic liver disease resolution. That means that their intrahepatic triglyceride content went to less than 5%, which I think is quite remarkable. Significant improvements were also seen in other parameters, including glucose, hemoglobin A1C, and lipids. So the presented results of this group of studies of GLP receptor agonists in people with HIV are really quite remarkable, but nonetheless, I think a lot of questions remain, such as long-term impacts in the context of aging, safety of these agents over the long term in persons with HIV, and really the impact of other organs in persons with HIV. The last two studies for discussion today address simplification of antiretroviral regimens in two distinct groups. In the first study, presented by Dr. Mounzer and colleagues, switched to bictegravir, FTC, and tenofovir alafenamide as a fixed-dose combination. Hereafter, I'll call it BF-TAF, plus lenacapavir daily, was assessed among persons with HIV on complex regimens. Groups were randomized 2 to 2 to 1. First arm was BF-TAF plus 25 milligrams of lenacapavir daily. Second arm was BF-TAF plus 50 milligrams lenacapavir daily. And the third arm continued their antiretroviral therapy. At 24 weeks, the results were quite good. 96.1 and 96.2% of individuals in both the BF-TAF lenacapavir arms were suppressed. 100% in the current antiretroviral therapy arm was suppressed. There was one individual in one of the BF-TAF lenacapavir arms who had actually a viral load at greater than 50 copies. These results are really supporting phase 3 studies that are just getting started. A dose of 50 milligrams of lenacapavir has been selected, and the hope is that the BF-TAF and lenacapavir will be combined, so there will be one pill once a day regimens available should the phase 3 trials prove efficacious for individuals even currently on complicated and complex antiretroviral regimens. And finally, there was a study from Kenya presented by Dr. Amajo and colleagues which evaluated efficacy and safety switching individuals who were greater than 60 years of age and on first-line regimens to BF-TAF. These individuals had to be suppressed for at least 12 weeks, though in point of fact, most of them had been on antiretroviral therapy for years. And they were randomized 1-to-1 to BF-TAF or to their current antiretroviral regimen. 95.8% of those in BF-TAF, 96.2% at 48 weeks had a suppressed viral load to less than 50 copies per milliliter, and 1.9% in the BF-TAF and 2.7% in the current antiretroviral therapy arm had a snapshot greater than 50 copies per milliliter at 48 weeks. So the virologic results were very similar. Where the results diverged, we're looking at outcomes. And actually, one individual taking BF-TAF discontinued, but 15 in the continued antiretroviral arm discontinued due to decreasing kidney function. Noteworthy is that 95% of individuals who came into this trial were on tenofovir TDF. So that is noteworthy. Also noteworthy was bone mineral density measured at the lumbar spine increased significantly more among those who were switched to the BF-TAF. So in conclusion, I think that individuals with HIV all over this world are aging. It's important all over this world to have safer, easier regimens. And I was really just glad to see this trial in Kenya that was so successful. In closing, thank you for joining us for episode 2. Please refer to the landing page for slides, and please be sure to come back tomorrow for episode 3 from CROI 2024. Thank you.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.